Thank you so much for having me out here today. It was a real pleasure to come out to Cortez and to get to see some snow, which I never get to see. And it's a real pleasure to come see the great work that y'all are doing back in Atlanta. We've been very impressed with all the work that y'all have done out here in a critical access hospital, and we're really excited about what y'all are doing. I just realized I've got an old date on here, so I apologize for that. But I did update the presentation except for that piece. Okay, I have no disclosures. They won't let me have any. Okay, so, just briefly what we'll talk about tonight, really want to talk about kind of what is the problem in outpatient antibiotic prescribing and why this is an issue and why CDC cares about it tonight. What's happening as far as identifying opportunities for improvement in outpatient prescribing, and we'll talk about this from the national level because that's what we're doing at CDC, but our hope is that health systems and clinics will sort of replicate this process at their own level, understand barriers to appropriate outpatient antibiotic prescribing, and talk about how we can potentially overcome these, and then close with our relatively new core elements of outpatient antibiotic stewardship, which released in November, which we hope will help you identify effective interventions to improve outpatient antibiotic prescribing. And I know Mark said there can be questions after, but if anybody has any burning questions or non-burning questions during, please feel free to ask. I'm happy to make this as interactive as possible. So you may have seen this. I know Jason and Namali have been out here before me, and those are rather large shoes to fill. But CDC estimated in 2013 that antibiotic resistance causes at least 2 million illnesses and 23,000 deaths each year in the United States. So this is why CDC cares so much about this, and we really do view this as one of the most pressing public health threats of our time. And it leads to an excess of $20 billion in direct healthcare costs annually in the US, according to this threats report that CDC put out. So you all know this, but just to be very clear, antibiotic use is the primary modifiable driver of antibiotic resistance. And this is pretty well demonstrated if you look at a timeline of antibiotics or a history of antibiotics. So these are the dates that a select few antibiotics were introduced. And if we overlay on top of that, maybe, the date that resistance was identified, which you can really see is that resistance is never far behind the introduction of an antibiotic. In fact, penicillin was introduced in 1943, but as you all know, it was actually discovered in 1928. So the resistance was identified before it was actually brought really out to market. But with all these other agents, it was not long before resistance was identified. So until we have a fundamental shift in the way we prevent and treat bacterial infections, we will always need to use those antibiotics that we have appropriately, because we'll always be hopefully a step ahead of the bacteria. But this is going to be a constant battle. So where does CDC and the Office of Antibiotic Stewardship really want to be? We want to see that every patient gets optimal antibiotic treatment, meaning antibiotics only when they're needed, and if they're needed, to get the right antibiotic at the right dose and for the right duration. So that's really the vision of our office. And so why do we care about the outpatient setting? Inpatient stewardship has really been the focus of a lot of stewardship work and also long-term care. But if we look at antibiotic expenditures in the US by treatment setting, this data is a little bit old, it's from 2009, but there were $10.7 billion spent on antibiotics in that year, and 62% of those expenditures occurred in community or outpatient settings. But expenditures really doesn't tell the whole data, because a course of amoxicillin costs a lot less than meropenem, obviously, or the inpatient drugs. So if we look at data from other countries, we really estimate that 80 to 90% of the use that occurs in humans is occurring in the outpatient setting. So this is why the outpatient setting really needs to be included in stewardship efforts. We really need to work across the spectrum of healthcare. Okay, so what are we actually doing here in the United States? How are we doing with antibiotics? And this is a work that we do and others do, and we look to what others do as well, to really identify the opportunities for improvement in outpatient antibiotic prescribing. So I'll take you through what we know about prescribing at the national level, but this is sort of similar to the work that we hope that health systems, again, and clinics will be doing for their own systems. So if we want to look first and see who is prescribing outpatient antibiotic prescriptions, we can look at pharmacy dispensing data. And if you look down at the let me see if this is going to, yeah, at the bottom here, in 2013, there were 268 million antibiotics prescribed, courses of antibiotics dispensed from retail pharmacies and community pharmacies in the US. And of those, 23% came from family practice physicians. And then physician assistants and nurse practitioners, when they're combined, did 8%. And the next is internal medicine and pediatrics. This is not surprising. These are mostly primary care fields. They're going to be seeing most of outpatients. So that doesn't indicate appropriateness, but it does help us understand who we need to be reaching out to and which groups need to be involved in outpatient stewardship. A somewhat surprising finding when we started looking at this data is that dentists prescribe 9% of outpatient antibiotics. That was the first time we looked at this dispensing data. That was a signal of, oh, maybe we need to figure out what's going on in the dental world. That has been somewhat of a challenge because the big data is not really there to help us with that as much as in the other settings, but it's a focus for what we're doing in the future. So then we also like to look at kind of how we're doing across the US and also how the US is doing compared to other countries. There's not a lot of really comparable international data, but in 2014, if you look at the rate of antibiotic prescribing per 1,000 population in the US, we prescribed 835 antibiotic courses per 1,000 population. And if you compare that to Sweden, which has comparable data but also happens to be one of the best performing countries and also one of the countries with the lowest antibiotic resistance rates, they were prescribing 328 per 1,000 population. And the interesting thing is Sweden thinks they have room to improve. They have a national goal of 250 per 1,000, so they think they're over-prescribing, and we're 2 to 3 times where they are. Now, our population is not the same, our healthcare system's not the same, but it is an indication that there's probably some inappropriate prescribing going on. And also, if we look by state, we also see a similar pattern here in the US, where the lowest state is Alaska, and often we see the lowest antibiotic prescribing rates out west, but Alaska was at 500, just over 500 per 1,000 population. The highest state in 2014 was West Virginia at 1,285 per 1,000 population. And again, I know that the population in California and West Virginia are not the same, but probably they're not so different that we should see 2.5 times the amount of antibiotics used in West Virginia is out in California or in Alaska. So this again suggests that we have some room to improve, particularly in some areas of the country. I'm probably supposed to be pointing back here, right? Instead of up this way. But that really, none of that helps us with appropriateness. So earlier, or really last year, we started a project where we looked at a large data set from CDC to see what are physicians prescribing or physicians and clinicians prescribing antibiotics for in the outpatient setting. And so these are the diagnoses leading to antibiotics in the US nationally in 2010 and 2011. And so sinusitis is the #1 reason that outpatients get antibiotics, contributing to 11%, followed by suppurative or acute otitis media with 9%. Most of that's occurring in children. Pharyngitis, and that's all-cause pharyngitis, not just strep. And then you can see coming down some of the other big infections that are leading to outpatient antibiotic prescriptions. So if you look down at the very bottom, you'll see viral upper respiratory infections contributing to 5% of all outpatient antibiotic prescriptions, and bronchitis also contributing to 5%. And these are patients where we've made sure they don't have sinusitis or suppurative otitis media or pneumonia or UTIs. And so these two infections shouldn't be on this chart. They don't need an antibiotic. That's very clear in national guidelines. It's been clear for a long time. And yet they're contributing to 10% of antibiotic prescriptions nationally. So a very clear target for us to go after to improve prescribing for those conditions or eliminate antibiotic prescribing for those viral conditions. If you want to look at children, I'm a pediatrician, so I always want to look at the kid data. For kids, not surprisingly, suppurative otitis media is our biggest issue, leading to almost 1/4 of antibiotic prescriptions, pharyngitis, and then sinusitis. But again, we still have viral uri leading to 7%, and bronchitis and bronchiolitis leading to 4%. So again, some clear targets for pediatricians and clinicians who see kids as well to improve. So from that work, we then set about to estimate, looking at all those diagnoses by age groups to figure out how many unnecessary outpatient antibiotic prescriptions there are in the US nationally. And this is a very, there was involved process. It's not terribly complicated, but it was somewhat involved. But if we sort of roll all that data up together, we estimated that at least 30% of antibiotic prescriptions written in doctors' offices and emergency departments in these outpatient settings that were surveyed in the United States are unnecessary, meaning that no antibiotic was needed at all. And then we have this other 70% that we called, quote, necessary. But we want to point out that, as you all know, appropriate antibiotic prescribing also means selecting the right drug, giving the right dose, and giving the right duration. And in this study, we didn't address that. So that 70% necessary still has quite a bit more inappropriate antibiotic selection, dosing, and duration contained within that. So we think it's quite a bit higher than that. But on the national level, that 30% leads to 47 million unnecessary antibiotic prescriptions per year. And so if you think about the impact that we could potentially have on antibiotic resistance or adverse events or C. difficile infections by eliminating almost a third of antibiotic prescribing, we could really do some good for our patients. And not surprisingly, when we sort of looked at big buckets of conditions that led to this 30%, our biggest driver is acute respiratory conditions. Things like sinusitis, ear infections, pharyngitis, bronchitis, URIs. And so for acute respiratory conditions, we actually estimate that 50% of those antibiotics are not warranted. They're not needed at all. So we then took the next step to look at antibiotic selection among the three most common conditions leading to antibiotics. I told you, I said a few slides ago that it was sinusitis, otitis, and pharyngitis. But we used that same national data set to look at that, and we looked at it in this data set by pediatrics and adults for the patients. And what we found is if we look at first-line antibiotics, or what we called first-line alternatives, so these are the guideline recommended agents. So for otitis media, this first line is amoxicillin. The first-line alternative is amoxicillin clavulanate or augmentin. And then the red is everything else. For sinus infections, it's going to be amoxicillin or amoxicillin clavulanate. Same for adult sinus infections. And for pharyngitis, it's penicillin, amoxicillin, and everything else. So if we look to see how many patients with those diagnoses are getting that first-line recommended agent, overall, it's only 52%. It ranges from a high of 67% for ear infections in children to a low of 37% in adults with pharyngitis and sinusitis getting the first-line recommended drug. And we estimated that at least 80% should be getting that first-line recommended drug. We all know that not everybody qualifies for the first-line drug. But if we think about the prevalence of penicillin drug allergies, which would make you choose a different antibiotic, about 10% of the population reports a penicillin allergy. So that's a reasonable reason a provider might choose not to give a first-line agent. That being said, only 1% of the population probably actually has a true penicillin allergy if they're properly evaluated, but 10% report it. And then at least for sinus infections and ear infections, probably at least 10% of visits are due to treatment failures. So they got amoxicillin, they're back because they're not better. So that patient would legitimately qualify for a non-first-line agent. So we expect it to be at least at 80%, and we're at half. So we have some work to do on selection as well. And the most common non-first-line antibiotic used was macrolides. And this is of concern because if you think about the pathogens causing sinus infections and ear infections, Streptococcus pneumoniae should be the first one we all think about. And the resistance to macrolides for Streptococcus pneumoniae is a major problem. In national surveillance data collected by CDC, it's actually 30% of invasive Streptococcus pneumoniae infections are with a macrolide-resistant strep pneumo. So azithromycin, or the most commonly prescribed macrolide, is an inferior agent for ear infections and for sinus infections to amoxicillin or amoxicillin clavulanate. And then for pharyngitis, azithromycin is recommended as an alternative for penicillin allergy. But again, we know that group A strep has macrolide resistance reported, and there's never been reported penicillin resistance. So again, it's an inferior agent. So it really should only be used in patients with penicillin allergy. So it's an example of how in the national data we see opportunities for improvement in selection as well as for opportunities for improvement in reducing unnecessary antibiotic prescribing. So I've kind of shown you where we are and what the problems are, and it's maybe a little bit of a dire picture. So the question is, are we making any progress at all? So this graph is actually from a tool that we have at CDC called the Antibiotic Resistance Patient Safety Atlas. And you can look at some of this data that we have of dispensed antibiotics in the national level and the maps in an interactive format. If anybody's interested, I'm happy to share the link with you. But anyway, so this data has from, and I'm sorry that the type's so small, but from 2011 to 2014, we can look at that dispensing data. In orange are children, 0 to 19 years of age, and in blue are adults, 20 years old and older. And so what you can see is we have actually made progress. So for all ages, when you combine them together, we've actually decreased 5% from 2011 to 2014 in overall antibiotic prescriptions dispensed per 1,000 population in the outpatient setting. So that's really good. But again, looking at this graph, what you can see is our improvements are in the pediatric age group. So pediatric prescribing for antibiotics has actually decreased 14%, which we're really excited about. Adults have not really changed, unfortunately. So there's a couple reasons probably why pediatric prescribing has improved. Obviously, pneumococcal conjugate vaccine was introduced in 2000, and then PCV7 was introduced in 2000, and in 2010 it was PCV13. So that's contributing. But the pediatric prescribing has been improving for a number of years. And there's also been a lot of focus nationally, both from CDC, from the American Academy of Pediatrics, from American Academy of Family Physicians, on improving prescribing for children. And I think we're seeing some of the fruit of that labor. There has been somewhat less focus on improving adult prescribing. And so I think we really want to see, we have a lot more work to do with children, but we want to see some of those gains start to happen in adults as well. So that's going to be a focus of our program going forward. Okay. So now you know what's happening on the national level, and hopefully you have some idea of where our opportunities for improvement are. Unnecessary prescribing, particularly for things like viral URI and bronchitis, and antibiotic selection for our common conditions. But why are providers prescribing antibiotics inappropriately? And it's really important that we understand why so we can help them improve. We really need to understand those barriers to appropriate antibiotic prescribing. So there's several options, several possibilities as to why this might be happening. So could it be a lack of knowledge of appropriate indications? Could it be a fear of complications? So if I don't prescribe this antibiotic, is my patient going to get a lot sicker? Are they going to get a brain abscess or mastoiditis? Is it patient pressure or satisfaction driving providers to do this, or is it habit? Have they just always done it and they're continuing to do so? So it could be, in some instances, a lack of knowledge. But in focus groups, providers generally know what they're supposed to do. I think all of us have probably heard ad nauseum, don't prescribe antibiotics for a cold. And providers know that. So that doesn't seem to be the major issue in the outpatient setting. And Mark can probably talk more about the inpatient setting. I think there's probably more of a deficit of knowledge in the inpatient setting. But for these common conditions, that's generally not the issue. So what is it? So what about fear of complications? So we know that providers and focus groups do cite the fear of infectious complications as a reason they provide at least more broad spectrum antibiotics than they are indicated, or prescribe antibiotics when they're not supposed to. So they're fearing a mastoiditis or a meningitis that might be missed and giving that antibiotic. So we need to really talk a little bit more about this. What if something bad happens to my patient? So there's the idea of what if something bad happens to my patient if I prescribe the antibiotic, but we also need to talk about what if that happens with the antibiotic as well. And I'm sorry I mixed this up a little bit, but with the antibiotic, you need to really think, I mean, we all need to think and talk about on the national level about complications from antibiotics. And so without an antibiotic, we can talk about how likely they are to get one of these complications, mastoiditis or pneumonia after a cold. And there are some very large epidemiologic studies that help us look at this. So from a study in Britain that looked at many, many thousands of patients, they calculated a number needed to treat for patients with a URI to prevent one case of pneumonia, and it was over 4,400 patients. And the number needed to treat for mastoiditis from ear infections is over 4,000. And so for these common conditions, these common respiratory conditions that don't warrant an antibiotic, really those complications are very, very rare. But with the antibiotic, there's my animations aren't working. With the antibiotic, we can also harm patients. So Clostridium difficile is one of the urgent threats that the CDC labeled an urgent threat. In 2013, they estimated that there were 250,000 C. difficile infections in the US per year, and it led to 14,000 deaths. There's been newer numbers that estimate that more at 500,000 infections per year and 15,000 deaths, and $1 billion in excess medical care costs. So we are really trying to talk more about the other side to make sure that the risk and benefits are appropriately weighed for antibiotics. And we really think it's a matter of patient safety. Beyond antibiotic resistance, we know that adverse events from antibiotics, they happen, and they can range from the minor to the severe. So side effects, we've all seen patients that have had rashes from antibiotics. We've all seen antibiotic-associated diarrhea. In my world, it's the diaper rash. You know, if I prescribe amoxicillin for an ear infection, I'm pretty sure that kid's going to get a diaper rash before that course is done. But they can also be life-threatening, so patients can have anaphylaxis. They can have C. difficile infection. And in national data, about 1 in 1,000 antibiotic prescriptions leads to an emergency department visit for an adverse event. And on the national scale, that leads to 142,000 ED visits per year for antibiotic-associated adverse events. And for children, they are the most common reason that a kid would come into the ED for an adverse drug event. And then beyond that, there's a lot of new literature and new evidence about the microbiome and the natural and normal microbiota that are supposed to be living on the human body. And so there's recent data that show that exposure to antibiotics during childhood are actually developed or associated with the development of juvenile idiopathic arthritis, or JIA, in children. It's not, this was an association. They didn't prove causality, but they did find a dose-dependent relationship, and they found the strongest association within a year of diagnosis. So we're starting to think about, it's not just the adverse event, it's just not just the C. difficile infection, but we may be changing the microbiota in a way that could affect, in particular, a child quite long-term. Exposure to antibiotics during infancy have been associated in some studies with elevated body mass index. That is, there is conflicting evidence about that. With food allergies, there's also another study about type 1 diabetes and some evidence about asthma as well. And all these associations are thought to be mediated through changes in the microbiota. There's a huge field, as you probably are all aware, of really understanding the importance of a normal microbiota and how perturbations to that normal microbiota could actually lead to long-lasting effects. So we really want to change that conversation about what if something bad happens to make sure that the risk and benefits are appropriately weighed, that the benefit of having an antibiotic and the risk of having it are weighed appropriately. All right, so what about patient pressure and satisfaction? As an outpatient provider myself, I feel like this is the elephant in the room. If we don't talk about this, providers are never going to listen to us because it really is a big problem. Providers universally cite patient requests for antibiotics as a reason they prescribe antibiotics when they know they're not indicated. And providers worry about losing patients to other providers if they don't give them what they want. So what can we help from CDC and on the national scale about that? Okay. So there's actually a number of studies. Most of them are either done in Europe or they're done in children in the US. But there's a number of studies that have really looked into this physician and clinician perception of patient expectations and how that leads to antibiotic prescribing. And so when they actually record visits, so they do an audio recording of a visit, of an outpatient visit, either for kids, it was done in kids in LA in the late 90s, and also in Germany for adult patients. They found that overt requests for antibiotics are rare. Patients, we tend to think that patients want antibiotics, but they don't come in and say, I want an antibiotic that commonly. But when physicians think that patients or their parents want antibiotics, they're more likely to prescribe. So in this study in LA, when they recorded these visits and they looked at expectations of the physician and the parents and what actually happened, for acute respiratory infections, they found that in 62% of the visits that physicians thought the parents wanted antibiotics, they prescribed an antibiotic. But only 7% of the time when they thought the parent didn't want an antibiotic, they prescribed an antibiotic. And the really interesting thing from that study is that physicians were actually really terrible at predicting which parents wanted antibiotics. So they would say, that parent wants an antibiotic, so I'm going to prescribe it. Or maybe they didn't say it, but that was sort of the subconscious thought process, but they didn't pick out the parents correctly. So something is going on where there's a miscommunication in the visit. So why do we, as clinicians, think that patients and parents want antibiotics even when they may not? And so a lot of this work comes from Rita Mangione-Smith, who's a pediatrician out in Seattle. But what she found is that physicians really thought parents wanted antibiotics when they had a few types of communication behaviors. So she called it when a parent suggested a candidate diagnosis. So this is where, in my world, mom comes in and she says, you know, Johnny has a really terrible sore throat, so I thought maybe it was strep throat. Or if the parent questions the non-antibiotic treatment plan. So if I say, gosh, your child has a cold, I think we need to do ibuprofen and honey for the cough, and mom says, we've been doing that and it doesn't work. That would be questioning the non-antibiotic treatment plan. That's an example of how a parent might do that. But the interesting thing is that parents who questioned the treatment plan were equally likely to expect or not expect antibiotics. Parents who suggested a candidate diagnosis might have actually expected the antibiotics, but they tended to be okay if they didn't get them, if the kid didn't have strep throat. So physicians were interpreting this as a request for antibiotics, but parents are probably trying to show engagement in the visit. They're probably trying to show, I didn't waste your time by showing up here, you know, I'm bringing my kid in tonight. But that miscommunication is leading to expectations that are driving prescribing. So what Rita Mangione-Smith and others have concluded is that there's probably two different conversations going on in that exam room, one that the physician's having and one that the patient's having, and they're not connected. I don't know about you all, but I'm sure that's happened to me a few times in clinic. So what they also found is that parents can really still be satisfied if they don't get antibiotics, even if they expected them, but they're dissatisfied if their communication expectations are not met. And so what did parents really want from these clinicians? They wanted an explanation of why their child didn't need an antibiotic. So, you know, your child has a cold, antibiotics are not going to help. But they wanted that in combination with positive recommendations, something to make their child feel better. So they found that combining the explanation and symptomatic therapy was really effective. And then they wanted a contingency plan. They wanted to know, if my child's not better in 3 days, should I come back then? Or if the fever gets higher, they wanted some sort of concrete steps of when they should come back. So here I am from CDC talking about the doctor-patient communication, which is a little bit strange, but the reason I'm doing that is because it turns out that understanding doctor communication and doing communication training can actually be an effective public health intervention to improve antibiotic prescribing. So there were some studies in Europe where they actually trained physicians, outpatient physicians, with enhanced communication training. And they found that it reduced antibiotic prescribing for respiratory infections in all ages. And they found that the effect appeared to be sustainable over time. So they did these communication trainings, and the interesting thing is in some of these studies, one arm was a communication training, and the other arm was CRP testing, C-reactive protein testing. Both, in the initial study, both arms improved their antibiotic prescribing. But 3.5 years later, the CRP arm had gone straight back to their old habits, but the communications training arm was still improved. They were still doing better antibiotic prescribing. And so that's somewhat unusual in stewardship, to have an intervention that continues to work after you've removed the intervention. So we at CDC are actually really interested in this, and we're hoping to be able to provide or to have some communication training tools that can help physicians and clinicians communicate more effectively with their patients and improve antibiotic prescribing. Okay. So we've talked about the first three and talking about what we can do about patient pressure and satisfaction. Effective communication can help. And I know that a lot of clinicians say, but it takes more time to communicate with my patient why an antibiotic is needed. But I guess my response to that would be, but your patient's going to be unhappy if you don't do it, whether you prescribe the antibiotic. So it does take more time, but it's really about providing good patient care, and it's what our patients want from us. So what about habit? So it turns out that some providers are just in the habit of prescribing antibiotics. This is driving some of our inappropriate prescribing. So there was a large study done in the VA. They actually looked at 1 million outpatient visits for acute respiratory tract infections, many of which did not require antibiotics, not all. But what they found is that provider variability was really driving antibiotic prescribing for these conditions. So their highest 10% of providers prescribed antibiotics in more than 95% of their visits for acute respiratory infections, where their lowest 10% of providers prescribed them in less than 45% or 40% of their acute respiratory infection visits. So one of the potentials of this is to find your high prescribing providers and intervene with them to try to improve prescribing. And then that also holds true in pediatrics. So in a pediatric network, it was actually Jeff Gerber's work out at CHOP, at the Children's Hospital of Philadelphia Network. They looked at antibiotic prescribing variability among their 25 pediatric practices, and they found that 18 to 36% of acute visits resulted in antibiotic prescriptions by practice. So some practices it was 18%, and the highest practice it was 36%. And this was kids with the same type of complaints. And then when they looked at broad-spectrum antibiotic prescribing, they found that the low practices were doing it in broad-spectrum antibiotics in 15% of their visits, and the high prescribing practices were doing it in 57% of their visits. And they concluded that in their Children's Hospital of Philadelphia network, that a child with the same complaint who presented to a high-use practice was twice as likely to get antibiotics and 4 times as likely to get a broad-spectrum antibiotic. So for them, that gave them some targets for stewardship to work with the high-prescribing practices. Okay, so now I hope that you understand a bit about why, I guess at least on the national scale, why this is a big problem, where we can improve, and why we think we have, why providers are still prescribing antibiotics inappropriately. And now I want to talk about what can we do and how can we improve prescribing. Does anybody have any questions? No? Okay. Okay. So you all, because you have Mark and your fantastic stewardship program, probably all know this, but not all clinicians know this. Antibiotic stewardship is really the effort to measure antibiotic prescribing, to improve antibiotic prescribing so that antibiotics are only prescribed and used when needed, to minimize misdiagnoses or delayed diagnoses leading to the underuse of antibiotics, and to ensure that the right drug, dose, and duration are selected when an antibiotic is needed. So we're really talking about the right antibiotic prescribing, and it's fundamentally, I hope you understand, about patient safety and delivering high-quality health care. We don't just want to reduce antibiotic prescribing at CDC, we want to improve it. We want to make sure patients get it when they need it and not when they don't. So there's been a lot of work done at CDC to improve antibiotic prescribing and use across the spectrum of healthcare. So you're probably aware, but in 2014, CDC released the core elements of hospital antibiotic stewardship programs, and that's really a framework for what makes an effective antibiotic stewardship program within an inpatient facility. And so that was 2014. In 2015, Namali Stone led the development of the core elements of antibiotic stewardship for nursing homes, and that really is also based on a program and what is the most effective, or what are the effective or critical pieces of a program that should be happening in a nursing home for antibiotic stewardship. And what we heard, at least from our stakeholders nationally, was that the outpatient setting was left out and we needed to address it. So in November, we released from our office the core elements of outpatient antibiotic stewardship. This was published for Get Smart About Antibiotics Week in the MMWR recommendations and reports, and is available at a website link that's probably about 5 times in this presentation if you need to find it. I'm happy to provide it to anyone. But really, the core elements, provide, the point of these is to provide that framework for outpatient clinicians and health systems to improve antibiotic prescribing within their practices. So who are the core elements of outpatient antibiotic stewardship intended for? Absolutely primary care clinics and clinicians, emergency departments and emergency medicine clinicians. EDs are technically an outpatient department. They obviously cross the line with inpatient. If the inpatient stewardship team is tackling the ED, we think that's fantastic, and we hope that will continue, but we certainly want them included, whether from the inpatient side or the outpatient side. Dental clinics and dentists. Again, dentists prescribe 10% of antibiotics in the outpatient setting, so we're hoping that they'll be engaged. Absolutely nurse practitioners and physicians assistants who are working in the outpatient setting. Specialty clinics, retail health, and urgent care clinics. This is a little bit of a black box for us on the national scale. We don't completely understand the prescribing patterns going on in these settings. We don't have good national data to help us with this, but we do want them engaged. And then healthcare systems that have outpatient clinics. So now I'll go through what our recommendations were in the core elements. And really, I hope that this will mirror what we've done on the national setting. You'll see it from that lens. But the initial step really is identify one or more high priority conditions for interventions. And these are what are your problems in your clinic? Where can you improve, your opportunities for improvement? So we know what they are on the national scale, but they may not be the same in your clinic. You may be doing great with URI, but maybe not so great with selection for pharyngitis or sinusitis, whatever your problem is. So common conditions that we know, at least on the national scale, can be improved. Conditions in which antibiotics are prescribed or overprescribed, so acute uncomplicated bronchitis. Conditions which are overdiagnosed. We haven't talked much about this, but group A streptococcal pharyngitis is often diagnosed in the absence of a strep test, which is not what national guidelines from IDSA recommend. They recommend confirming the diagnosis with either a rapid strep test or a throat culture before prescribing antibiotics, so it's an overused diagnosis to justify an antibiotic prescription. Conditions in which the wrong dose, duration, or agent is used. Again, in the national data, we see that azithromycin is commonly used for sinusitis, not recommended in national guidelines, not a good choice for sinusitis. Watchful waiting or delayed prescribing is underused. So in my world, this is acute otitis media. The American Academy of Pediatrics recommends watchful waiting as an option for children with non-severe otitis media. We can talk about who qualifies for that, but for those that qualify, that is an option, or delayed prescribing. And so that's a condition in which that could be a priority. We don't recommend delayed prescribing for bronchitis or strep-negative pharyngitis because antibiotics aren't indicated. So this is really where national guidelines recommend that as a good option. And then where antibiotics are underused. Sepsis, obviously, for the ED. Sexually transmitted infections are another one. So the reproductive age woman who comes in with dysuria maybe gets diagnosed as UTI, but chlamydia is missed. So that's an underuse problem. Okay. Second, identify the barriers that lead to deviations in best practice. So in your practice, what is it that clinicians need to help them improve? And again, it's not always clinician knowledge gaps. I would argue that pediatric UTI might be the one where clinicians need a lot of help with knowledge. There's not good national guidelines on what to pick. But for these other things, make sure you're thinking about patient satisfaction, your high prescribing clinicians, fear of complications, that sort of thing. And then establish your standards for antibiotic prescribing. If you don't know what you're supposed to do, how are you supposed to measure and improve? So like what y'all are doing with your pediatric URI, UTI, adult URI and UTI guidelines, making sure you know what's expected. And these can be system-specific, they can be clinic-specific, or they can just be implementing the national clinical practice guidelines from the national healthcare societies. Okay, so then in the outpatient setting, we've moved a bit away from the program that we're using in the inpatient and the nursing home setting. We think if you have a program and that program can extend to cover the outpatient setting, that's fantastic. But outside of a healthcare system or outpatient clinics that are connected to a hospital that already has a program, that might be a big lift if you're a 2 or 3 person practice and independent practice. You may not have the infrastructure for a program, so we really focus more on the processes that we hope everyone can do across the spectrum of outpatient medicine. So the first one is commitment. Demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. Action for policy and practice. So implement at least one policy or practice to improve antibiotic prescribing. Assess whether it's working and then modify as needed. This is a pretty classic quality improvement, do a cycle. Tracking and reporting. And these 4 all appear in all of the core elements. But tracking and reporting is very key. Monitor antibiotic prescribing practices and offer feedback to clinicians about how they're doing. If it's a solo practice or a very small practice, it may be that clinicians have to assess their own antibiotic use. And then education and expertise. So provide educational resources to clinicians and to patients on antibiotic prescribing, and then ensure access to needed expertise on antibiotic prescribing. And we'll talk about each of these a little bit more. So in the actual document that we put in the MMWR, we divided these interventions for each core element by those that we felt like a solo practitioner could do. So if you're a single doc out in practice, we hope that you can at least do what's under the clinician guidelines. What's under the organizational leadership would take more infrastructure to do. That being said, if an organization really likes this intervention better and it feels like it's going to work better for them, as long as you fulfill one from either category, we are very happy with that. So for those of you that are working with Telegen or the CMS QuinnQAOs, any of the above apply. You don't have to pick from organizational leadership because y'all are a larger, well, a health system. Okay, so for clinicians, single clinicians can write and display public commitments in support of antibiotic stewardship, and we'll talk a little bit more about what that means. If you have a larger organization, you can identify a single leader to direct your antibiotic stewardship activities within your facility, very similar to the hospital program. Include stewardship-related duties in the job or in their position descriptions or job evaluation criteria, and then communicate with all your clinic staff to set patient expectations. It's not very helpful if a doctor goes in and they're not going to prescribe antibiotic, but the nurse has already said, you know, oh, Dr. Smith will probably prescribe antibiotics for you. So really making sure that everyone's on the same page makes it a lot easier to communicate with patients. So the public commitments, it sounds a little corny, but it's actually really evidence-based. So the public commitment poster is a very simple intervention, and it was published in JAMA Internal Medicine, well, I guess 3 years ago now. And it was a poster placed in exam rooms, and it had a clinician picture and signature and a commitment to use antibiotics appropriately. And they did this simple intervention in a randomized controlled trial, so in a very rigorous way. And they designed what this sort of seemingly corny, simple intervention using principles of behavioral science. So behavioral science says that we all want to be consistent with our previous commitments. So if I tell you I'm going to be somewhere on Saturday and I don't show up, you know, I don't want to do that if I've sort of made this public commitment to be somewhere. So it's the same idea. And so the idea is to remind the clinician at the time of the patient encounter that they've committed to use antibiotics appropriately. And they call this a behavioral nudge to make the right choice. And it's a nudge because there was nothing punitive about it. Nobody came behind them and said, you didn't make the right choice, but it was just a reminder. And so they had a long letter, but at the end of the letter it said, as your doctors, we promise to treat your illness in the best way possible. And we are also dedicated to avoid prescribing antibiotics when they are likely to do more harm than good. And the interesting thing was they showed a really impressive reduction in inappropriate antibiotic prescribing for respiratory infections. So they had a 20% decrease in inappropriate antibiotic prescribing compared to their control groups, and it was statistically significant. And this is really low cost. So we obviously work with state health departments quite a lot, and we've been promoting this intervention because we think it's really pretty simple, and it fulfills your commitment core element. But Illinois Department of Health really liked it. They have a version for Illinois doctors. This version is from Texas, from actually a Medicaid provider, provided that to their providers, and then this version's from the New York State Department of Health. And now we also have one on our website, and we worked with the authors of the study to create a letter. So the letter in the study looked just like this. So it really was a letter posted on the wall. You add your picture and your signature. We don't have it in Spanish yet, but we will. And then you post it in your exam rooms. So if you're interested in commitment posters, you can print them off right here. Okay, so action. Again, at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and modify as needed. So for clinicians, use evidence-based diagnostic criteria and treatment recommendations. Hopefully we're all doing this, but keep current, keep updated. Use delayed prescribing practices or watchful waiting, again, when appropriate, when recommended by national guidelines. For organizational leadership, provide communication skills training for clinicians. We've already talked about why we at CDC think this is really important. It's because it's evidence-based and it works. Require explicit written justification in the medical record for non-recommended antibiotic prescribing. This is actually from a JAMA study. I'm not going to go into it, but happy to provide more information about any of these to anybody who's interested. And there's more detail in the text as well of the core elements. Provide support for clinical decisions, so clinical decision support tools where that can be helpful. Use call centers, nurse hotlines, or pharmacist consultations as triage systems to prevent unnecessary visits. Patients with colds really don't need to come in. If somebody can help them feel better before they come in and do a visit, that's one prescription or antibiotic prescription that may not happen. Okay, so we know that it's not that easy to keep up with all the national guidelines that are constantly being updated, so we try to help. So on the Get Smart Know When Antibiotics Work page, we have links to summarize the adult treatment recommendations for common outpatient conditions and the pediatric treatment recommendations for common pediatric conditions, but you also have them for your health system as well, so please use those. Okay, tracking and reporting. This one's probably going to be the hardest, I think, for most outpatient clinics, but we do think it's really important. If you're a solo clinician, it may be that you have to self-evaluate your antibiotic prescribing practices. But we're hoping that there'll be more of these continuing medical education and quality improvement activities that can track and improve antibiotic prescribing. So for those of you who take care of kids, there's currently a module from the American Academy of Pediatrics called EQUIP, that at least for the pediatricians will fulfill your maintenance of certification part 4, where you pull your own charts, look at your prescribing for common infections, and then hopefully improve over the course of doing that course. For organizational leadership, implement at least one antibiotic prescribing tracking and reporting system, and then assess and share performance on quality measures, so things like the HEDIS measures. So there's a HEDIS measure for avoiding antibiotics for acute bronchitis. So if that's being collected by your payers or by your health system, that can be fed back. So what did we suggest you should track and report in your outpatient facility? It really depends on your opportunities of improvement. So we hope that you're pulling some baseline data or figuring out where your problems are, or at least talking to your clinicians to say, where do you think we need to improve? So options are to look at, again, those antibiotic prescribing for one or more high priority conditions, which antibiotics were not indicated. You can look at percentage of all visits leading to antibiotic prescription. So there have been studies where they haven't really looked at diagnoses. They've just purely looked at percent of all visits leading to antibiotic prescriptions, and they've been able to show improvement. At the healthcare system level, you can look at complications of antibiotic use, so adverse drug events and C. difficile infections, or antibiotic-resistant trends among common outpatient bacterial pathogens. But the caution with this last one is if it's a small clinic or a small area, you may not see much there, and there may not be power for those. So just be careful with that. And then I want to talk a little bit about peer comparisons, because we call this out pretty clearly in the document. Because the outpatient literature is fairly clear that if you do audit and feedback or you track and report to clinicians, a key piece of that is to provide peer comparisons. So how am I performing compared to the other doctors in my practice? So there was a study out of, again, Children's Hospital of Philadelphia Network, and they compared their clinicians' antibiotic selection patterns for respiratory conditions, so things like sinusitis, pharyngitis, to their colleagues' performance. And they just did your colleagues' average performance, but they showed that they had an increased use of guideline recommended agents with that study. That occurred as long as they continued to do the peer feedback and the comparison. When they removed the intervention, everybody reverted back to their old habits. So for at least this one, you probably have to sustain it for it to work. There was another interesting study out of a group at Harvard and UCLA where they compared the clinician's percentage of inappropriate prescribing for acute respiratory conditions, things like colds and bronchitis, to the top performers in their practice. So they are the group that works with the behavioral scientists, and they didn't want to drive people to the mean. They wanted to drive them to the best performers. And so in this study, you either got an email that said, congratulations, you are a top performer. You prescribed no antibiotics out of your 20 visits for bronchitis. Or you got an email that said, you are not a top performer. You prescribed 10 antibiotics out of 20 visits versus the top performers who prescribed none. And that was the email. And it went out to all these Harvard docs and these UCLA docs, and they did not like it, but they did better. I wouldn't be very happy, but it probably would make me pay attention. And then another interesting study was done actually in the National Health Service in England. They notified clinicians they were prescribing more antibiotics than 80% of their peers. And they just looked at all antibiotics. They didn't look at diagnoses. And so they got a nice little letter. It said, you are prescribing more antibiotics than 80% of your peers. Here's some ways you can improve. And in that one, they had it signed by Dame Sally Davies, who's the head of the National Health Service. And so they did that on purpose to kind of get people's attention. And they led to a decreased overall antibiotic prescribing and cost savings in that particular study as well. So what we've gathered from the outpatient literature is if you're going to do tracking and reporting, it really needs to come with a comparison to how your peers are doing. There's different ways to do it, but that needs to be part of it. All right. So lastly, education and expertise. And so for clinicians, we really think this is about educating your patients. So clinicians can use effective communication strategies to educate their patients when antibiotics are and aren't needed. They can educate about the harms of antibiotics treatments, and they can provide patient education materials that give them that information about symptomatic therapy and contingency plans and the things that they want to hear from us. For organizations, it's about educating your clinicians. So some places do academic detailing, that face-to-face, one-on-one, or one-to-small group educational training can be very effective. Continuing education activities for clinicians can be helpful. Passive education strategies where the clinician's not really engaged doesn't work as well as the active, like academic detailing or things like peer feedback. And then ensure timely access to persons with expertise. So we felt like in the outpatient setting, it was a little bit difficult to say every outpatient clinician should have access to an ID doctor or an ID pharmacist. And that may vary what you need, but we all need consultants at various times. In pediatrics, I sometimes need an ENT to help me put ear tubes in a kid that has recurrent otitis. Or maybe I need a general surgeon to help me manage a patient appropriately. Often I need an ID doctor to help me manage a patient appropriately. And so really thinking about who those consultants are for your practice and making sure that all the clinicians in your practice have access to those appropriate consultants. So we don't want to, we have a lot of patient education materials. So one place you can go if you want information to educate your patients is, again, our website, Get Smart Know When Antibiotics Work. We're trying very hard to build out additional materials to help clinicians with the core elements. But we have a patient section. We have lots of different things on our website that you can use. Some new information that we rolled out this year. We're always rolling out new information. We have a fact sheet on ear infections, which includes a section on watchful waiting that can be given to patients. We have prescription pads, or at least information on delayed prescribing. Wait, don't fill your prescription yet. Your provider thinks you may get better on your own. Watchful waiting and delayed prescribing, so things that you can hand out to your patients. If you like our materials, we hope you do, and they're freely available, and you can print out as many as you like. Okay. So this is our website for the core elements of outpatient antibiotic stewardship. Again, we're building it out as much as we can, adding things as often as we can, so we hope this will be a good resource for clinicians in the community. We really want this to be a collaborative process. We want to help clinicians improve antibiotic prescribing, so we see decreased antibiotic resistance, decreased C. difficile infections, decreased adverse events nationally. We want patients to get the right treatment. Okay. So in summary, outpatient prescribing in the United States can be improved. I hope you have gotten that message. There's wide geographic variability. You all do a lot better in Colorado than we do in my home state of Tennessee or down where I live now in Georgia, but we can all improve. 30% of outpatient antibiotic prescriptions in the United States are unnecessary. We didn't talk too much about it, but we actually have a national goal that came out of the White House to reduce inappropriate outpatient antibiotic prescribing by 50% by 2020. So we're really looking for a 15% reduction in all outpatient antibiotic prescribing by 2020 from our 2010 levels. Providers prescribe antibiotics inappropriately for many reasons, but certainly fear of complications drive them. But we can help them by making sure they're including adverse events into that conversation and risk calculation, perceive patient expectations, but hopefully effective communication can help, and habit. Certain providers are just in the habit of prescribing, and hopefully we can help them change as well. And then antibiotic stewardship is one of our most important strategies at CDC to combat antibiotic resistance and keep our patients safe. The core elements of outpatient antibiotic stewardship provides that framework for improving outpatient antibiotic prescribing based on evidence. It is relatively hot off the press. Our 4 core elements are commitment, action for policy and practice, tracking, reporting, and education expertise. All of us can be antibiotic stewards. And you will have the opportunity to be a core elements pioneer because we really just rolled this out in November. You've got a great health system that's already really leading the way in stewardship. And so we'll hope that you will also lead the way in outpatient stewardship as well. So with that, thank you for listening to me tonight. And I really hope some of you have some questions. I'd be happy to answer any questions that you have.